Let me turn the presentation over to Shannon Royce, Director of the Partnership Center. Shannon?
It says I can't start my video, Ben, because you've stopped it. I'll leave that for you to figure out while I introduce our program. Hello, my name is Shannon Royce, and I serve as the Director of the Center for Faith and Opportunity Initiatives, also known as the Partnership Center. There I am. Hold on just one moment. I'm going to make Ben our host again. Forgive me, we are going through some learning with a new Zoom web platform. We had to switch over the beginning of June, so we're all learning a few new things here. So thank you for joining us. We're so grateful you're here with us. This webinar is the fourth and final webinar in a series that's focused on mental health challenges and the COVID pandemic. Up until this point in the series, we focused on how non-mental health professionals can address mental health impacts of COVID-19. So we've been talking to faith and community partners about how they can engage in mental health services. But today we're turning our attention to mental health professionals and how they need to consider and address spirituality in the midst of the COVID-19 pandemic. We will introduce our speakers in just one moment. But first, a few housekeeping things just to remind you of some details before we get started. This is an educational webinar. It's not intended for press purposes and is not on the record. If you're a member of the press, we'll be happy to connect you with our press office at the end of the program. If you're having difficulty hearing us, we find that often using the call-in number at the bottom of your screen is a better way for you to hear clearly and well. And so you might want to try that if you're having some trouble. Sometimes your internet connection, wherever you are, isn't as strong as it needs to be to get really clear audio. So if you have trouble hearing, just go ahead and use your phone to call in. We will be sending a link of the slides and the webinar to you within the next couple of days. We are recording the program today, and so watch for that email. And if you have any questions related to that or other things, you can email us at partnerships with an S, partnerships@hhs.gov. Finally, we have a really full program today, 3 magnificent speakers. We're really looking forward to this. So if you have questions that you want presented to the speakers, we will get to as many of those as we can at the end of the program. Just go to the bottom of your screen where you see Q&A and type your questions in there, and we will do our best to get to as many of those questions as we can. So now, thank you. Let's get to our webinar. Here at the Partnership Center and at HHS in general, we have been really focused in recent months on COVID-19 and making that a major priority of our time and resources. We continue to work to connect faith and community partners to the challenges being faced in our communities because of COVID-19. Today, we're going to hear from some mental health professionals who advocate for fellow clinicians to engage spirituality and religious belief in their treatment protocols to the benefit of their clients and their patients. First, we will hear from Dr. Paul Summergrad. Dr. Summergrad is the chairman of the Department of Psychiatry and professor of psychiatry and medicine at Tufts University School of Medicine and psychiatrist in chief at Tufts Medical Center. He has served in multiple leadership positions, including as the president of the American Psychiatric Association and is past president of the American Association of Chairs of Departments of Psychiatry. He has published extensively with over 150 publications and has edited 3 books, including the textbook of medical psychiatry. We're so honored to have him with us today and look forward to hearing from him. After Dr. Summergrad, we will hear from Dr. Lisa Miller. Dr. Miller is professor of psychology and education at Columbia University Teachers College and is the founder of the Spirituality Mind-Body Institute, the first Ivy League graduate program in spirituality and psychology. Dr. Miller is a foremost scientist on spirituality across the lifespan, with her work published in top research journals, including JAMA Psychiatry, American Journal of Psychiatry, and the Journal of the American Academy of Child and Adolescent Psychiatry. Her innovative research has focused on quantifiable effects of spirituality in health, resilience, and thriving, and an overall sacred and joyful life. Her clinical and consultation work focuses on spiritual awareness and spiritual growth for individuals, families, groups, and organizations. We're so grateful to have her join us today to share her perspective. And finally, we'll hear from Dr. Holly Oxlander. Dr. Oxlander is the Associate Dean for Research and Faculty Development and an Assistant Professor at Baylor University's School of Social Work. Dr. Oxlander studies the ethical and effective integration of clients' religious or spirituality in mental health care, including whether and how mental and behavioral health therapists discuss their clients' religious, spiritual beliefs in treatment, client preferences for such integration, and methods of evaluating and training religious spiritual competencies across various mental health professions. She's developed and studied tools and theories to help clarify the role of mental health practitioners, religion, and spirituality in clinical practice. So as you can see, we have three incredibly competent people to share with us today, and so we really look forward to hearing from them. Dr. Summergrad, we'll turn it over to you.
Thank you very much, Ms. Royce, and thank you so much for the work that you are doing and HHS is doing in so many areas related to this terrible pandemic and COVID crisis, and very much appreciate the chance to join with such accomplished colleagues who are great experts in this area. I'm not sure I'm an expert in the same way they are, but I will try to speak a little bit about this. Let me see if I can share my screen with you. And let me get this up for you. So I want to talk a little bit about the challenges of faith and mental health, and stealing from Daniel Defoe what he called the plague years. Now, hopefully this will not be years, but it wouldn't be surprising if an event like this lasts for a couple of years. And I think part of the struggle that we all have with this as we confront this is so new and it's so uncertain, and it has such a, as an illness, has such a, what we would sometimes call in medicine, pleomorphic, meaning lots of different ways it can show itself. Sometimes very benign, asymptomatic, in other cases, terribly deadly and lethal. So whenever we're dealing with something like this, we have to deal with the realities that we are encountering, not only uncertainty, but also encountering mortality. These are my disclosures. None of them are relevant to this presentation, but I want to make sure I'm obligated to show that to you. This is from Michael Levitt, who's former Secretary of Health and Human Services in the George W. Bush administration, Bush 43. And he wrote that everything we do before a pandemic will seem alarmist. Everything we do after a pandemic will seem inadequate. And certainly for all of us, this has been very disruptive. And again, that disruptive quality and that unpredictable quality stimulates all of the encounters with uncertainty and obviously morbidity and mortality that people struggle with in life, and that we as a culture, in some ways, we've been so fortunate because we've had such a successful country that we've been able to work towards reducing so many of the burdens of illness and disease, and yet here this comes, if you will, out of the blue. And the impact on us and the impact on social isolation associated with this this illness is one that that obviously generates not just spiritual challenges, but other kinds of challenges as well. And in that sense, we're dealing with several interlocking crises. An infectious disease pandemic with a novel virus, so we know very little about it. an economic crisis induced by a response to achieve reduced community spread, which we've done, but it's kind of like putting our economy temporarily on hold and all the challenges that creates for people. And a spiritual and existential crisis, which I think we talk about a little bit less, associated with disruptions to plans, hopes, dreams, health, and in some cases, life. And I think in thinking about the spiritual and existential part of this, I'm reminded that there's a famous Stoic phrase, which in the Latin is memento mori, which means remember death. And the story is told that Emperor Marcus Aurelius, who was a great general and a Roman emperor, when he would enter the Colosseum and people were cheering for him, he had someone walk behind him and whisper in his ear, "Remember thou art dust." And when we are faced with a circumstance like this, where all of our expectations can be wiped away so quickly, and we don't have great defenses against this emotionally, psychologically, the reality is we then face not just isolation, but potentially mortality. And for many of us, this can disrupt our views of our life, our world, where we're going, all of which can generate very important and very necessary spiritual dimensions to this crisis. The mental health sequelae of all of these are foreseeable, and they fall into several categories. Not all of the categories represent mental illness. A lot of them represent normative stress, normative anxiety with uncertainty and isolation, but over time there are increased risks as well for formal disorders of PTSD, post-traumatic stress, depression, potentially suicide, particularly associated with both ill health and worsening economic circumstances. And again, colleagues in the UK early in the epidemic published this on the psychological impact of quarantine, noting, looking back in the literature to earlier pandemics, the challenges of post-traumatic stress, confusion, anger, depression, with longer quarantines, infection fears, frustration, boredom, and also all of the financial and economic challenges. And we know this is occurring in a setting where we are already dealing with what have been called deaths of despair. And this just shows the rise in what are called poisonings by our public health colleagues, which really means overdoses, in many cases opiate overdoses, suicides, chronic liver disease, often associated with alcohol use, challenges which we have been dealing with over the last really over the last decade. So as we think about this, as I think about this as a psychiatrist and as a physician, what makes it so hard to talk about the spiritual elements, or how can we bring the spiritual elements into this dimension? And frankly, it's hard to imagine how the spiritual and existential elements of this illness are not immediately present when we have people who are dying alone in hospitals or can only reach out to family members through FaceTime or through Zoom. When I first began to work in this area, when I was president-elect of the American Psychiatric Association, I was at a meeting that we had convened with a lot of faith leaders and a lot of psychiatrists and other mental health professionals. And one of the people at that meeting said, the first time I had ever heard this, said that mental illness is the no casserole disorder. And what they meant by that was that if you get sick, and you have cancer, or you have heart disease, people will come to your house and they'll bring you food and they'll check in on you. If you have a mental disorder, people generally don't do that, or do that less than they do for other conditions. There's a certain stigma or distance associated with this. And so consequently, talking about mental health has always been somewhat difficult. Part of the reason it's hard is because our language is not great. When we say someone has a mental disorder, the mental is their symptoms, but not necessarily their cause. In the 19th century, the most common cause of mental disorders in the United States in the late 19th century was syphilis, which is an infectious disease. We use the term mental illness as if we're talking about one thing. We say people with mental illness. We don't generally do that for physical illness. We talk about specific disorders. We sometimes think that mental disorders are these things that happen over somewhere else in the mental health care system, but they happen in our communities, just as spiritual crises happen in our communities. And we know that churches, mosques, synagogues, Faith-based organizations of all kinds are often the first place that people turn to when they need help, when they need support, and frankly, when they need community. And these things are not just happening to someone else, they're happening to our brothers, sisters, parents, children, and to ourselves. Our science is really complex. It's hard to talk about mental disorders because we're talking about, in some measure, the brain, and we're also talking about social structures, both of which are really complicated, but we have made a lot of progress in improving things. At the same time, the boundaries between culture and religious traditions and mental disorders and psychiatry and mental health care is not always clear. Cultures and religious traditions are rightly and appropriately concerned with how we live our lives, how we take responsibility for ourselves, how we generate a sense of meaning. And mental disorders affect the most intimate parts of ourselves. The stigma associated with them is not just external, it's also internal. And it makes it these are very private conditions, as are spiritual challenges, as are spiritual dimensions. So the boundary between all of these things, mental health, psychiatry, psychology, and faith, can be very unclear. And there's a tendency, as we've discussed, to stigmatize this. Abraham Lincoln, who suffered from severe depression, particularly after the death of his first love, Anne Rutledge, wrote in a letter to Mary Speed, his business partner's sister, that a tendency to melancholy, which was the 19th century term for depression, let it be observed, is a misfortune, not a fault. So it's really important, as we do in religious and spiritual traditions, to try to get beyond blame, to come to acceptance, and to come, frankly, to love. So one of the things that we did at the American Psychiatric Association when I was president was to try to generate a faith-based guide. And the guide was really for practitioners in mental health and substance use disorders, but also for clergy of various kinds. And we had many clergy from all denominations join with us in that effort. And it's available as a PDF. I'll show you the link where you can download it. And it has a broader discussion of these issues and some of the boundaries. How do I know when I should refer someone? How can I, as a psychiatrist or psychologist, do a better job of asking my patients about their relationship with God or a higher power or whatever they believe is spiritually meaningful for them? How are the things that are affecting them affecting their sense of where they stand in the world, and the ground, whether the ground is solid underneath them, not just from a mental health perspective, but from a spiritual perspective. And there's also a quick reference guide, which is kind of a little bit of a cheat sheet in case you need to refer quickly to see whether it's something that you need to deal with, particularly for faith-based leaders. And that's available at psychiatry.org, which is the American Psychiatric Association website /faith. So I think as we move forward in this very challenging period, again, I want to come back to this question of uncertainty and isolation. One of the things that our religious institutions do is they minister. They minister to communities. They bring communities together. And whether you're, as sometimes it's called, the Friday people, the Saturday people, or the Sunday people, depending on your religious faith, Muslim, Jewish, or Christian, or whether you're Buddhist or Hindu or whatever your background might be, there is one of the core experiences is having a community that supports one another, that supports our aspirations, and supports us particularly at times of enormous transition and stress. And right now, all of those things are challenged. It's hard to be together in person. It's hard to do funerals. It's hard to do visitations of families who've lost loved ones. It's hard for our hospitals to be able to allow the kind of visitation we would normally allow, to let family members be present in the way that they have to be and patients want them to be, and we as doctors and nurses want them to be. So again, thinking about this and working with our religious colleagues, but also making sure we think about these very profound issues that people are experiencing is very critical during this period. And more casseroles, please. We need to find ways to reach out to each other. especially when on top of the mental health stigma, we have all of the needs for social distancing and all of the needs for physical distancing that make isolation greater. So finding ways to reach out again in whatever way we can to feed each other, both physically and morally and spiritually and medically, is very critical for us. Thank you very much for this opportunity to talk with you this afternoon.
Thank you so much, Dr. Summergrad. We really appreciate your insight and your thoughtful presentation. And now we'll turn to Dr. Lisa Miller. Dr. Miller?
One second, Dr. Miller. Let me ask, see if Dr. Summergrad can make me the host again. This is Ben Odell with the Partnership Center. And let me make Dr. Miller the host. Okay, Dr. Miller, you should be ready to go if you come off mute and start your video.
Can you see my slides?
Yes, we can see your slides, Dr. Miller. Go ahead.
Terrific. Good morning. It's wonderful to have this opportunity to speak on such an important matter. And I want to thank Shannon Royce and Ben Odell for their extraordinary work. It's a time where many people have retreated, and instead you've been real responders and stepped forward for all of us. Right now I'm sharing with you slides. Let's see here. Can you see this? I'm wondering if I might hand this over to IT to run the slide. Should we do it that way?
That's fine, Dr. Miller. If you can just make me the host again while leaving your video up. Just one second, everyone. Dr. Miller, go ahead.
Okay, thank you. So could we start with the first slide, please? Thanks. Thank you. I'm coming to you into this discussion as a scientist of 20 years looking at spirituality and mental health, and in particular, examining both the foundational pathways of resilience and recovery, as well as the foundational human endowment for spirituality and religion. In the United States, as many of you may know, there is, if you might consider an overlapping Venn diagram, about 2/3 of people in our country consider themselves to be both spiritual and religious. They say that my deep personal spiritual life is held in the richness of my faith tradition, its texts, prayers, community, and practices. 30% of millennials and fewer with each older generation say I'm spiritual, but not religious. And a small number of people will say I am religious, but I don't know what you mean by this spirituality. So in brief, a great number of people in our country are foundationally spiritual in the way they look into daily events. And while, next slide, please, scientists could not begin to, I'm sorry, one more slide, define spirituality, scientists can identify threads within spiritual life that have an enormous impact on our health, on our recovery, and on the many things that unfold from that deep spiritual core. So if I may, I'm going to review very briefly what we now have roughly 20 years of good science, 10 years of excellent science, the most recent 10 years on spiritual life as it relates to mental health. And in particular, in this discussion, I'm going to focus on the side of mental health that has to do with adaptation to trauma and prevention against suicide. Okay, the 4 foundational major findings, which I will share with you an overview. They can be brought up in greater detail. I'm sorry, next slide. Are here. I have put them out here in aggregate, but again, if you pull up PsycInfo or Medline or even a Google Scholar search, you can pull up a great number of specific studies relating to these. I've also, in my book, chronicled them in the reference section. The Spiritual Child. The Spiritual Child has a large bibliography in the back, and there's many, many science studies related to this discussion. The Spiritual Child starts in childhood, takes us through adolescence, and I'm going to try to go now all the way into adulthood. The first finding that we can say broadly put is that every human being is innately spiritual. There is a capacity through which we experience the transcendent. It is a perceptual capacity. It is a way of being, and we know that it's innate because if we look at twin studies, starting in 1997 with Ken Kendler and his colleagues, moving into longitudinal twin studies in the early 2000s, we see that the capacity through which we experience the sacred and the transcendent is 1/3 innate, 2/3 environmentally shaped, which means that while we are all born naturally spiritual beings, there is enormous impact of our family, our teachers and faith communities, and those who shape us. Briefly, in adolescence, there's a surge, a biological clock, if you will, not marked only by age, but physical puberty. And there is a 50% increase in this heritable contribution, such that if, as we find around the world in all faith traditions and in rich indigenous cultures, we support with biological puberty the formation of the spiritual core, we now, final point, have a strong science that says, next slide please, there's nothing as profoundly protective against the most prevalent forms of suffering with puberty, depression, anxiety, addiction, and risk as a strong personal spirituality. A teen 1 standard deviation above as compared to below the mean, and a tendency to say, I turn to God for guidance in times of difficulty is 80% less likely to become addicted than a teen a standard deviation below the mean in personal spirituality. And so to 60% less likely to have deep major depression and 70% less likely to be taking dangerous risks in boys, outward physical risks, driving fast, jumping off high places. In girls, less likely to have unwanted, intimate, and sexual experiences. So given the magnitude of the protective benefit, the huge, huge scale of the impact of spiritual life, it is really remarkable to think that we would do nothing to help young people form the spiritual core. It is, if you think about the formation and the developmental through lines that emanate from a deep spiritual core, there's almost risk imposed through ignoring this deep formative process. Now, next slide, please. If we look, for instance, at the very prescient and elevated rates of suicide, the rates of suicide now approach those of death by auto accident in high school students. And there has never been a time at which that was the case. We need to examine the extent to which personal spiritual life may play a role. And also look, next slide, please, hand in hand with the emphasis both of spiritual life in young people, but that now extending to early adulthood, middle adulthood, where now the risk has never been this high, 14 deaths per 100,000 in people 40 to 50. So how could this be? Perhaps the best study on suicide that I've seen was a meta-analysis, a study of studies conducted over 2,000 tragically completed suicides and 5,000 matched controls by Wu and colleague 5 years ago. And Wu found that overall, there's nearly a 2/3 decreased relative risk of completed suicide if I have a strong personal spiritual life. And that goes up to 71% in theistic Western cultures and 81%. I'm 4/5 less likely to commit suicide compared to matched controls, matched for wealth and poverty, matched for ethnicity and risk, matched controls. 4/5 less likely if I have a strong personal spirituality exercised in a faith community. Next slide, please. These are some of the studies, next slide please, showing the quantitative groundwork of the meta-analysis. And finally, this is just a comment that although we are in many ways non-conversant about spiritual life in the public square, there are times where it's really to our peril to punt. We really need to engage this in a way that is inclusive, in a way that is welcoming and constitutional in the public square, in a way that includes everybody, because to ignore spiritual life is effectively to set up harm. Next slide. So let's focus now, because we're moving quickly into this time before us of hardship and a great number of traumas, as my very illustrious colleague spoke about. We have never faced such a, in the past 2 or 3 decades, broad and pervasive collective trauma since perhaps Vietnam. And so let us consider the role of spirituality, not only in treatment, but in a deeper form of recovery. There is a difference between symptom alleviation and development, growth, and renewal, as we know well as mental health providers. And it turns out that recovery and renewal, symptoms of suffering, and processes of regeneration often can go hand in hand. In a very large study by TSAI 2015, he found that 50% of vets with trauma symptoms often also have at least moderate post-traumatic growth. Okay, next slide, please. This is a sample of over 3,000 vets. And in fact, if you look at the center of this inverted U-shaped curve, the vast majority of people with meaningful and moderate levels of trauma also are showing meaningful post-traumatic growth. It's at the way left and the way right. On the way left, where there's less acute symptoms. On the way right, where there is perhaps a flooding of symptoms that we see people need extra support. But it is normatively how we are built that left treated or untreated, there is a process of post-traumatic growth. Next slide. But what might be the leverage points for mental health providers? How do we facilitate post-traumatic growth? It turns out that, and this may not surprise you as providers, that the memories themselves, the trauma itself, as held in our psyche, is grist for the mill. The availability of traumatic memories actually facilitates post-traumatic growth, flashbacks, dreams. And at the same time, access to our deep spiritual core, access to existential questions, as was brought up by my colleague before, openness to spiritual awareness, that the highway has been paved, as my colleagues in Newtown after the massacre said, that you built the ark before it rained. There is some core, some spiritual core into which to reach, to access for a sense of connection to God or the universe, whatever language yours might be, to access some sense of buoyancy, of being held, of carried through, if, as some say, lifted on the wings of eagles, when we are very much without. Next slide, please. And so, next slide, thank you. And one more slide. This process of post-traumatic growth can be facilitated, and if it is, it becomes a foundational way of coping with loss, disappointment, moral injury, and even spiritual injury, which is to say a feeling of disconnection from one's higher power. God, Allah, Hashem, the universe, life itself, whatever our through line to the sacred and the infinite and the transcendent. When we cannot feel that in a state of spiritual injury, we will have, for having worked together through post-traumatic growth, a way to grow, a way to regenerate. Once set up, this lasts across the lifespan. If we set it up in a teenager, it's there in midlife. If we set it up in someone in their 40s, it's there in our older years. This is a process, a stance of leaning into suffering. Ben, how am I doing on time? Next slide.
Dr. Miller, you have about 3-4 minutes left.
Okay, in that case, I want to quickly point out, when we develop a stance of post-traumatic spiritual growth, we are augmenting the process of recovery to one of renewal. And it is in many ways continuous with on the other end of the spectrum, building the strengths, what are often called the positive psychology, character strengths and virtues. And this entire continuum is done in a much deeper and enduring way when, for the 85% of people who identify themselves as highly spiritual in our country, 4 out of 5 people who come to your office, we engage the spiritual core. I want to share with you a bit of the strength of the formation of the spiritual core, and you can see its continuous through line. Next slide. This is a sample. This was published in JAMA in 2014, JAMA Psychiatry. Miller, Wickmoran, and Weissman, there's other authors too. It's with my colleagues at Columbia Medical School. The broad and pervasive regions you see represented in red are regions of cortical thickness. In brief, the cortex's processing power, a thicker cortex tends to be associated with strength of processing. And in this particular study, we looked at those structural regions of the brain shown to have thicker cortex in people with a sustained spiritual life across the lifespan. In people who from 26 to 38 to 45 maintained a stance in living that when rain clouds come, and they certainly do, when loss and disappointment and trauma comes, and they will, there is a spiritual way to lean into that process. And for having over time consistently said spirituality is highly important to me, those people, that way of living went hand in hand with these regions of strength, if you will, these regions of cortical thickness in the brain, which were in the parietal, occipital, and precuneus, which are regions of reflection and perception. So as you know, the brain is in many ways the lens through which we see the world. And I can live with the same terrible disappointment in the same house, with the same family, on the same cul-de-sac, and the way it looks is seen through the lens of the brain. So in many respects, by way of analogy, there's something of the use of a muscle. And the more we use that muscle, a spiritual response to suffering, the more it's there as a very perceptual present lens, which ultimately affects our sense of who we are and where we live in the world and who those around us really are. Ken Kendler and his colleagues found that with each successive depressive episode, it's easier to get depressed the next time. The trip cord becomes lower, the threshold is lowered. Because I develop under the rain cloud of depression, a depressogenic way of thinking. I am such a loser, bad things happen to me. This is the way the world is, it cheats you. That way of thinking makes me predisposed next time around to having another and deeper depressive episode. However, if in response to great suffering, I develop a spiritual response with your help, the next time a loss comes around, I look through the lens, if you will, of the red brain, and I see life will carry me forward. God is by my side. This door shut, but if I pivot, perhaps the very nature of life is that the next door will open. That deep way of being is a perceptual way of being, and you're looking at it right here. The particular brains you're looking at are brains of people who are at high risk for depression. Both they are at high risk because of their family inheritance genetically, and because they're at high risk because of their family environment, depressogenic rain clouds. It turns out that it is especially the case for people in high-risk families. A strong personal spirituality, we published this in American Journal of Psychiatry in 2012, strong personal spirituality is 75% protective between the ages of between the ages of 26 and 38, okay? Adulthood, childbearing years, amongst people who are both high and low risk for depression. But in people at high risk for depression, familial risk for depression, a strong personal spirituality is 90% protective against recurrence of MDD, American Journal of Psychiatry 2012. These are those people. You're looking at their brains. The people who at 26 say, I turn to God for guidance in times of difficulty. My personal spirituality is highly important to me. Lifted on the wings of eagles. Those folks you see there are 90% less likely to have a recurrence of MDD if they have a strong personal spirituality. So it is absolutely within our work as mental health providers. And if someone comes to me with severe depression, I know that I'm both treating them for the now, but I'm setting them up for the rest of their life course. And furthermore, if I'm silent, when I know that this is one of the 4 out of 5 people with a deep personal spirituality, whether Jewish, Hindu, Muslim, Christian, or no religion at all, a deep personal spirituality, then to remain silent by omission, am I creating iatrogenic harm by depriving them of the adult developmental framework that will be there to manage now and the tumultuous times ahead? So this is our opportunity, and I send it back to you.
So good. So good. Thank you, Dr. Miller. I really appreciate it. Let's try something different this time and have you pass hosting directly to Holly. It'll save us a step instead of going back to Ben. Oh, Ben's got it now. We've got this under control. We are skinning a cat. I hope I don't have any cat lovers out there. Okay, Dr. Oxlander, turning it over to you. Thank you so much.
Thank you, Shannon. I so appreciate it. Well, hello, everyone. Thank you to Shannon, to Ben, and to the whole Partnership Center for offering these fantastic webinars during this difficult time. And thank you to each of our attendees for joining today. I've been watching as these numbers have come, and I'm just so honored by your presence and your willingness to tune into today's conversation. I also want to begin by especially thanking those of you who are mental health care providers and faith leaders specifically. From the bottom of my heart, thank you for all that you are doing right now in this season to care for and protect those you serve. In the last few months, we have watched you shift to online sessions and sermons and services to remain connected while maintaining social distancing as you continue to support those you serve. Thank you for the endless ways in which you are nurturing the well-being of those who look to you for guidance, wisdom, hope, support, and permission to grieve and to wrestle with our new reality. Your presence and the work you do matters to so many of us right now, and we are deeply grateful for the ways that you are tenderly caring for us to the best of your abilities. Now, I also want to offer a long overdue request that has been at the heart of my research for the last decade, one that is even more relevant today and in the months ahead than it has ever been. To mental health care providers, please consider the role of your clients' religious and spiritual beliefs and practices, whatever they may be, as you hold space for them navigating these uncertain times. Assess their spiritual struggles and strengths, and consider potential referrals and resources across faith traditions. And to faith leaders, please consider your congregation members' mental health concerns and needs, whatever they may be, as you plan your sermons, discern ministry opportunities, and consider referrals and resources tied to mental health care. Some of you have been considering this intersection on faith and mental health in the lives of those you serve for as long as you've been in your roles. However, as fellow researchers and I have found in our studies, many have not. Whether you have or not, and recognizing that few of you received training on this intersection, my request is that you begin considering it today and to take one small step to begin bridging this gap. First of all, we are all waiting in a heavy state of collective overwhelm and uncertainty, each of us having our sense of normal drastically change, and often on a day-to-day basis. This is one of the first reasons why we need to be thinking about this. We're all doing the best we can with the energy, resources, access, support, and attention that we have to give. And this includes the faith leaders and mental health care providers who are supporting others. We're recognizing that we will have a tremendous amount of need around mental health, substance use, post-traumatic stress, abuse, and suicide in the months and years ahead. We're seeing the access to crisis hotlines rise immensely alongside online therapy programs. In fact, SAMHSA reported in April of 2019 that there were nearly 1,800 texts to their crisis line. In April of 2020, it was 20,000. Among those contacting the crisis text lines, 78% are experiencing stress or anxiety related to the coronavirus. We're also beginning to collectively recognize the trends around how inextricably connected our faith and mental health are, as my colleagues just noted in their studies, particularly in this season too. On May 4th, the Washington Post reported our nation's mental health needs rising in their article, "The Coronavirus Pandemic is Pushing America into a Mental Health Crisis." 5 days before that came out, the Pew Research Center reported that a quarter of Americans are saying that their faith has strengthened during this pandemic. As we grieve our illusion of control, many of us are discovering our faith and our mental health overlap in ways that we may not have been mindful of before. While these rising numbers point to this connection tangentially, researchers have been studying this complex intersection for years. I know Dr. Harold Koenig will soon have his 3rd edition of the Handbook on Religion and Health coming out that continues to gather studies that have explored this intersection for decades. In the spirit of the evidence-based practice process, particularly for mental health care providers, we absolutely must be paying attention to the impact on treatment outcomes when we integrate our clients' faith. And not only should we pay attention to the impact on treatment outcomes, but we need to listen to what clients are saying, particularly around their preferences when it comes to mental health treatment and integrating their faith, and we need to respond accordingly. In a national survey that my research team did in late 2018, funded by the John Templeton Foundation, we found that 64% of current mental health clients in the US agree that their faith is relevant to their mental health. 20% disagreed and 16% were neutral on that. About 2/3 also said that engaging their religious and spiritual practices improves their mental health and that their beliefs motivate them to become mentally healthy. So not only do clients also report that their faith impacts their mental health, but we also found that about 62% said that the healthier they feel mentally, the more they want to engage in their religion and spirituality. And this article is forthcoming in the journal Social Work. These areas of our lives are intimately connected with one another, and truthfully, to silo or separate them in this season could negatively impact those that we're trying to help, particularly given the power differential between faith leaders and mental health care providers and those they serve. In faith settings, not communicating about mental health leaves attendees wondering what the congregation thinks about it, or worse, making assumptions. In mental health care settings, we need to ask whether clients' faith is important to them and to let them know it's okay to talk about this topic as it relates to their clinical circumstances. This is important because those facing mental health struggles may find themselves leaning on or questioning their higher power during difficult times, engaging in spiritual practices to cope, or seeking support from their faith community. These areas of our lives can be woven together to support healing by combining healthy coping mechanisms with a grounded faith in a divine love. And at the same time, they may be connected as we wrestle with our faith, face spiritual trauma, or engage in negative religious coping. In both settings, we need to take a disposition of being a curious and humble learner, continually identifying opportunities to learn more around this intersection, while working within our ethical guidelines, professional training, and referring appropriately. Certainly, it's worth remembering, though, that our ethical guidelines does include seeking consultation, support, and resources from others who have training in this area. Further, this nudge to consider the intersection between faith and mental health isn't just for those who you serve, whether as a faith leader or as a mental health care provider, but as a fellow helper, we cannot offer to others that which we don't reflect upon and offer to ourselves. To the best of your ability and regardless of your personal faith and or mental health background, I hope that you will offer yourself the space that you need to tend to your own spiritual and mental health needs in this season, especially as you hold space for others' needs. You are worth caring for. In March, I did a Q&A with Baylor that you can access by scanning that QR code using your phone's camera. But one of the points that I really want to highlight from that article is something that Father Richard Rohr teaches us, that if we do not transform the pain, we will most assuredly transmit it, and usually to those closest to us. We must engage in something tied to our faith, regardless of what we believe in, and to be consistent in the practice, continually learning to surrender that sense of control that we're all navigating right now. In addition to paying attention to our faith, we also need to be paying attention to our mental health. Perhaps we engage in some deep breathing exercises or intentionally get outside to get into some sunlight each day. Or when our brain is flooded with thoughts and information and emotions, we can ask ourselves some of the grounding questions to return to the present moment, such as, what do I smell right now? And what do I taste? And what do I see in front of me? What can I touch and feel the surface of? And what do I hear? I'd also recommend tuning into our bodies during this time and paying attention to what the tension, the aches, and the exhaustion are telling us, to listen to those in the same way that we listen to our emotions and our thoughts. And last and most importantly, do not hesitate to reach out if you are noticing any changes in your appetite, your mood, your sleep, your behaviors, thoughts, or feelings. Reaching out for help with your mental health is a sign of courage, not weakness. And it needs to be as normal as going to the doctor for symptoms of a physical illness. Some sites for finding a therapist include Psychology Today or Help Pro. And if you or a loved one are deeply struggling, please contact the National Suicide Hotline at 1-800-273-8255. Now, previous speakers have offered a number of rich resources that I would highly recommend you circle back to and check out. And I don't want to duplicate those, but I did want to add a few others. Under the resources tab on my website, I have a long list of resources regarding this intersection, including freely available instruments for mental health care providers and recommended books and trainings, including SETMH, which is an online training for spiritual competency and mental health treatment. I also have a monthly newsletter that I send out that includes resources on this intersection, summaries of articles that I've published, and updates on some of the projects that I'm doing, including a book that I'm currently working on. If you're a podcast listener, I host a weekly podcast called CXMH, where we have conversations on the intersection of faith and mental health. And some of our guests actually include those who've been on these webinars in some of the previous ones. Our audience is about a third faith leaders, a third mental health care providers, and a third of those who have or love someone with a mental illness. So we try to target our topics to those. I also haven't seen this particular site promoted or on the previous webinars, but COVIDmentalhealthsupport.org is a site that has pulled together many of the crisis lines into one space and has support from many of the top organizations. And finally, I want to elevate this crisis text line, particularly for healthcare professionals and essential workers, especially since many of you on this call today are among those frontline workers. Now, before I close, I want to ask each of you to write down, and seriously, write down one thing or one takeaway that you have that you will implement within the next few days. I'll offer a few ideas. If you're a mental health care provider, perhaps you read about some more research on faith and mental health, explore some spiritually integrated interventions tailored to your client's belief system, and begin asking about client spirituality in the intake form. Or perhaps you check out the Religious Spiritually Integrated Practice Assessment Scale that's on my website and reflect upon your own views and behaviors related to integrating clients' faith. If you're a faith leader, perhaps you spend some more time with the Center for Faith and Opportunity Initiative site to see what other resources exist at this intersection, or to begin including mental health resources within your community's newsletter. Perhaps you partner with a nearby school of social work for a social work intern to help with mental health needs in your congregation, or to partner with other local congregations to collectively hire a full-time mental health care provider on staff. But for both groups, I would honestly recommend setting aside some time to, first of all, practice some self-reflection and self-care around this intersection. Also, begin the awkward work of picking up the phone or sending an email to faith leaders and mental health care providers in your community, and beginning to connect, to learn from one another, and to dream about ways that you can be working together to serve those in your communities. Particularly in light of what we're seeing around those crisis lines that I had noted earlier, your communities need you right now, and y'all need one another too. So I'm going to close with this. To mental health care providers and faith leaders, truly thank you for all that you are humbly doing right now to serve others, especially in this season. You are invaluable to our communities, and my hope is that you can lean on and learn from one another as you collectively care for your communities, for those you serve, and for yourselves. Thank you.
Thank you so much, Holly. I really appreciate your being with us today. If you can turn the host back to Ben, that would be great, at the Partnership Center. We are coming very close on our time, so we don't have a lot of time left for questions. But I did want to raise one question, really, that each of you touched on directly or indirectly right now. And that is that we have seen an increased risk of suicide-related issues as a result of this COVID crisis. People are struggling with isolation and everything that goes with it, that lack of control that Dr. Summergrad spoke about. I just think this is a really significant issue. So I would love to hear just briefly from each of you, if you'd take a moment, just to nutshell how spirituality relates to concerns of suicidal ideation. And Holly, you touched on some of the practical things folks can do, but if we could just speak to this for a moment as the one question that we'll address at the end of this webinar. We'll start with you, Dr. Summergrad.
So first of all, I really appreciated my colleagues' wonderful presentations, really great material. I would say that, one of the things about spirituality, and Dr. Miller spoke on this in her talk, was about, the qualities of resilience and being able to withstand some of the slings and arrows associated with just being a human being and being alive in the world. I would say, one of the things around suicide is we do know that economic downturns affect mental health and affect the suicide rate. But there's also some contrary data that suggests that in the middle of disasters, or unusual circumstances, perhaps a little bit different than this, which is more ongoing, there may be a temporary reduction in the suicide rate too. And again, I think the sense of being part of something together, communal connection, the sense of being part of something larger than oneself, all of which go back or can go back to spiritual experiences, or a sense of togetherness that transcends the self, can also be protective for individuals. So again, I think we'll have to see how this all plays out, but I think the sense of not being isolated or alone is extremely important for people to be able to withstand these circumstances.
Absolutely. Dr. Miller or Dr. Oxlander?
Sure. Lisa Miller here. I have seen in faith communities people at their absolute bottom, just despairing, people who have profound shame, people who have profound depression, side by side, quietly praying together. And I think for people who are people of prayer, or people who meditate, or people who convene in a way together that engages the sacred, the transcendent, their higher power, to do that together is profoundly supportive and profoundly healing in a way that being alone, as was just said, it is also very important, but to pray together, to meditate together, to observe together. So there are faith communities, as you know, online. People attend synagogue, church, temple together online. There are also people who one-on-one connect online or over the phone. And I think that for instance, as in AA. So this notion of shared spiritual life really is the crash mat. And in fact, in my work with the military, I work extensively with the Army, 50% of people there and outside the Army as well, first contact their clergy before contacting mental health, because they identify their own suffering as having spiritual roots. I tend to take people as knowers of their inner life And if someone comes and says there are spiritual implications, where is God where in this moment? I start there with them.
That's so good. Thank you, Dr. Miller. Dr. Lander, any last thoughts?
Sure. I would first of all echo what my colleagues have just shared, and I think that their wisdom is on point in terms of this and how do we think about this. Lisa had some great data around spirituality as a protective factor when it comes to suicide, but I also want to really elevate the fact that we have data that shows that when individuals are in crisis, they tend to go to their faith leaders first, asking for prayer and asking for support when it comes to their mental health struggles. And so one thing I really just want to reiterate is, again, building more of these bridges between faith leaders and mental health care providers so that when those individuals do face those suicidal thoughts and ideation, that the faith leader can quickly get them the support they need, because their lives matter so much to us. And so that would be the piece that I would add.
Could I just,
Yes, sir.
1 second? I think it's really important that, again, you know, to reiterate that when people have persistent symptoms, when they are unable to get out of a state of anxiety, apprehension, they're not sleeping well, they're not eating well, they're agitated, they're acting in a way that is discontinuous from the way they ordinarily act, it's really critical to get, you know, professional guidance from, you know, one's primary care doctor, psychiatrist, psychologist, other mental health professional, social worker, whoever that might be, in addition to reaching out to faith leaders. And often faith leaders will reach out to mental health resources that they know and trust. But
Absolutely.
these are conditions where we can intercept devastating consequences and also can treat very effectively in many, many circumstances. So I don't want that to be forgotten in here.
Yes, sir.
Thank you.
No, thank you. I really appreciate your mentioning that, Dr. Summergrad. I think this really is a nice way for us to bring this to a close because the Partnership Center have done significant work in the bridge building between the faith community and the clinical community. We have a new resource that we will be launching the beginning of next week, our Compassion in Action Guide. And it is all about engaging the faith community in the work of mental health care and community, but understanding that they don't do the clinical side of the picture, that they need the relationships that both you, actually all three of you have mentioned, the importance of those connections and relationships. So we look forward to that. We have our next webinar 2 weeks from now on the Compassion in Action Guide. And between now and then, we will work out the kinks in the new Zoom system we are using right now so that it will go a little bit more smoothly on the technical side of the picture. But we're really grateful that you've all joined us today. We thank you for the knowledge and expertise shared by our guests today. And we will be sending out the recording to all those who registered for this program, along with the slides of our speakers. So stay tuned to receive that in the next 2 or 3 days. We're grateful for your participation with us, and this concludes our program. Thank you so much.
Thank you, Shannon.